Hello, I am Dr. Kanti Bansal, infertility and IVF specialist from Ahmedabad, Gujarat. Today I am immensely happy because I have this great opportunity to speak on a subject that is very close to my heart, and that is polycystic ovarian syndrome. Now, basically I will first tell all about polycystic ovarian syndrome in a very short gist, I must say, in a nutshell. It's a really vast topic and a subject, but it is necessary for everyone, especially in India, to know about this dreadful disease. Initially we used to call polycystic ovarian syndrome as polycystic ovarian disease, but as our knowledge on polycystic ovarian syndrome increased, now we have coined this as a syndrome. We all know syndrome means there are various organs in the body which are affected. So initially what the clinicians were thinking was that just one organ, that is the ovaries, are affected, but now we know it's not only the ovaries, but in PCOS various organs are affected like ovaries, kidneys, liver, the whole of the cardiovascular system, the skin, etc. And so it is, in short form we call it as PCOS, or many non-clinicians also term it, or laymen term it as POX. Now PCOS afflicts many people in this world. I will just confine to our country. In India, over the past 10 years, it's rising in an alarmed condition, so to say. Initially we were thinking it was just around 20 to 25% in India, but it's shocking to know that it's around 36 to 40% now in India. Now as far as infertility is concerned, because that is the topic or the subject where I am more practicing, and around 70% of infertile women who are having ovulation problems, the cause is because of polycystic ovarian syndrome. Now talking a little bit about the origin, how do we get this PCOS? So supposing we want to know the cause of PCOS, it is not a single cause, and what I can term is it's a heterogeneous origin. Now what do we mean by heterogeneous? Heterogeneous is more than one cause, and there are mainly three causes. One is genetic. Genetic plays a very important role. Second one is lifestyle, and the third important cause of this PCOS is environmental factors. Now after knowing about the origin, the amount of incidence that PCOS is there in our country, now let's understand why are we speaking so much about PCOS, why are we wanting to do so many public awareness programs, etc. That's because we want to decrease the incidence, which is difficult, but we can always control this PCOS. And another problem with PCOS is it has a lot of impact on adolescents, on women who are in the reproductive age group, and also on women who are premenopausal, menopausal and postmenopausal. Now I will describe you all why it is so. In adolescent group, the girls are having a lot of problem because of acne, hair growth which is not wanted, male pattern hair growth, hair loss, and also they are obese, and they have a very low self esteem. I have seen patients who also have suicidal tendencies and are extremely depressed. This is about the adolescence. Now coming to the reproductive aged women. In this reproductive aged women, they are unable to get babies, they are unable to conceive, and it's not just one treatment. When they come to us, we need to really see what's the real cause. Even in PCOS, we have a lot of phenotypes, we need to know what is wrong with them, etc. Then in the menopause and postmenopausal women, the problems are many more, because these patients sometimes they have gestational diabetes in pregnancy, and when they grow older, these are the women who will definitely are going to have diabetes, they are going to have hypertension, they may have cardiovascular system problems, and myocardial infarction, any you name it, and they may have it. And that's why, friends, I feel it's very, very important for us to recognize, realize how important it is to properly diagnose this condition and then treat it. Now, when I told about the origin of this syndrome, I said genetic, I also said it is lifestyle and environment. In both lifestyle and environment, genetic we really can't contribute too much. Maybe we'll have to do a lot of research before we go and find out something for this genetic origin. But as far as lifestyle and environmental conditions are concerned, I think we can help them by giving, advising them about proper nutrition and how they have to decrease their weight, etc. Another important thing is these days we also know that there are two conditions in our gynecology. One is endometriosis and the second one is PCOS, and these two conditions are we are actually putting them in the group of immunomodulatory diseases. And so when we consider that in PCOS immunity is hampered, then there is a thought, or it is clearly now understood, that all these patients of both endometriosis and PCOS should be given nutritional supplement or nutraceuticals which help them to improve the immunity, and the basic problem of immunomodulation is corrected in these patients. And I run a PCOS clinic, specialized endometriosis and PCOS clinic from more than about 10 years now, and I have made it a rule to give all my patients antioxidants and immunomodulatory drugs and some nutricals, so that these patients are able to cope up in a better way. And I've seen that these type of nutrients really help these patients. Now I want to give now I'll talk a little bit about how to handle these patients of PCOS, especially the adolescents. These are some tips from me to the patients. Coming to the adolescents, I would advise them to really take this PCOS seriously, sincerely. Go to a proper doctor, gynecologist, or nowadays everything is there on the net. Let them search on the net, find out a proper doctor, and go and take advice. I also feel the parents also should accompany these children, so that the parents also understand the depth of the problem. Another thing is that they should not too much indulge in going on the net. We do find Dr. Google a very good tool, but then everything that is written on Google is not really the correct way it should be. So the best advice, the best medicines, the best lifestyle management a doctor can give. So this is my suggestion. Another thing is, please do not think that this is the end of the world. PCOS is so common. So many girls of your age have PCOS, so you will be all right. First of all, you have to have a very positive thought in your mind that you are going to be all right. All your problems, your acne, your hair growth, your hair fall, everything will be solved by taking the proper treatment. We have lot many treatment options for you all, and that will be done. For girls who are obese, my first advice would be they should have lifestyle management, they should opt for proper exercise and diet, take the guidance of somebody, a dietitian, a physiotherapist, a doctor, and then do the needful. I have treated so many obese girls in my clinic, and all of them have lost at least 10 to 15 kilograms of weight, and they have maintained thereafter. So there is a no, okay, that is one thing. And please have a very positive self esteem. This is for the adolescent girls. Now coming to the reproductive age group of patients, I would advise that whenever you are diagnosed with PCOS, I think it would be better if I understand in this era it's not possible to marry very soon, because you all have career and you want to become a woman of substance, etc. But then you can always take some time and think about the problem that you're facing and try to match everything properly in your life. Try to see that you are not delaying your marriage very much, and even after marriage try to get pregnant. And in case you're not getting pregnant, you are having very irregular menstruation, you're obese, please consult a proper infertility specialist and you'll be helped. And it's not that all these PCOS patients have to go and take very high tech treatment. You can get babies even with just taking tablets or just reducing your weight, your ovulation can come back. And for the patients who are in the menopausal group, I would suggest that you all have a proper regular monthly examination, yearly examination done for all, like complete body health checkup, have your diabetes checked, have your blood pressure checked, have a complete body profile so that you don't miss anything. Please visit the physicians. Don't take it lightly, because life is worth living properly. And if you have anything like blood pressure, diabetes or any other dreadful disease, things become very difficult. And this is about for the patients. Now I move on a bit to the doctors, my colleagues, and mostly gynecologists who are practicing. Whenever we have patients of PCOS coming to us, we should have a lot of empathy for them, especially when they come in the adolescent group, because they are distressed. We all have a very busy practice and we do not really have that much time to counsel. But I tell you, counseling is one of the most important factor as far as PCOS is concerned. When these girls come, we know everything about PCOS, but the innocent girls will not know. So we have to guide them, educate them. Supposing you're such a busy practitioner that you're really not able to sit with them and counsel them, you can always refer them to a proper dietitian or some person who is doing a proper guidance for the physiotherapy or decreasing the weight of the patient. It's very important, because as I told you, the origin of this disease is lifestyle. So they have to change the lifestyle. Lifestyle doesn't mean that it's only diet and exercise. They have to also change their pattern of living. We have to make them understand that the time clock that is there, generally these children, they read late in the night, they get up very late in the morning. They have very different timings for everything. We have to tell them they have to have discipline in life. Once their clock is set, then everything becomes in place. So they have to have a sort of a military regime, may not be that much strict, but something like that. Then when we come to the diagnosis of this PCOS, I would advise when the patient has come for the second, third time and not getting proper response with the medications, etc., please get the complete profile of PCOS done for them. Just to elaborate, we have to get the T3, T4, TSH, because many times this PCOS is associated with thyroid problems. Prolactin may be increase. Then we have to also, many of these patients are having androgenism, hyperandrogenism. So we need to check their LH. FSH and LH ratio is altered. LH is raised. Now what about in hyperandrogenism? We also know that the testosterone levels are raised. So we have to get both the free testosterone and the total testosterone. In some of the patients, the DHEA may be raised. So we need to get a DHEA test. A little bit about the insulin resistance, because many of the patients are having insulin resistance. So if the insulin resistance, how do we know? There are symptom signs like thickened black skin on the neck, on the abdomen, etc., that you can check. But then these patients may be obese. But then what about the test? In that we have to do a fasting blood sugar and a fasting insulin. Nowadays people also opt for HOMA. There is a very easy equation for finding out the insulin resistance once you do the fasting insulin and fasting blood sugar, and that should be less than 5. Now another very important test for diagnosis is in the married women who want to conceive is the transvaginal sonography, where we see the ovaries, the size of the ovaries, the volume of the ovaries, and also the anti-follicle count. Now after doing all these tests, we understand now what does the patient have. Does she have hyperandrogenism? Does she have insulin resistance? What is it? Once we find out all this, then we treat accordingly, give them ovulation induction. Initially for ovulation induction you should start with the oral ovulatory drugs. All these years clomiphene citrate was the first line of treatment, but right now letrozole, and just 2018 it has been drafted that letrozole is the first line of treatment. Now we have different issues like clomiphene citrate resistance, clomiphene citrate failure, and combination of giving letrozole and gonadotropins, etc. You all can opt for all these treatment, and it's a very vast subject, so I'm just touching upon these things. And please advise all your menopausal and premenopausal patients to have their regular body checkups, etc., so that they don't get the late complications or sequelae of this dreadful disease. So I think as far as the patients are concerned, I have a brochure wherein I have written about PCOS. I have written several blogs on PCOS, and for the doctors I do have a very beautiful book known as Decoding PCOS, which you all can refer to. So once again I think it's really great to have this discourse on PCOS, which is so important at the point of time, and also I believe first in very small, important, easily available treatment like what I said, antioxidants, nutraceuticals, lifestyle management, and then go in for more complicated or very sort of extra or such treatment. So with this I would like to say bye. I would now like to address the patients of the reproductive age group, and this is for the doctors, clinicians, maybe the gynecologists who are practicing infertility in their own way. And there is a consensus as far as how we should go in for the treatment as far as the PCOS patients coming with fertility problems. The first line is the oral ovulagens. That means the tablets which can be given orally and they will induce ovulation. The second line of treatment is a combination of oral ovilegins with gonadotropins or gonadotropins and laparoscopic drilling. And the third line of management is IVF. Now coming to the first line of management, that is the oral ovilegins, we have to remember we have two options here, clomiphene citrate and letrozole. Initially clomiphene citrate was considered as the first line of treatment, but now it's proved beyond doubt that letrozole is the first line of treatment. So whenever these patients come to us with this problem of infertility, we have to keep in mind that just giving them these oral ovulations, they will not really have ovulation. We should see that these ovaries are sensitized, and to know whether these ovaries are sensitized or how do we sensitize, we should see that if supposing the patient has very irregular menses and her LH is very high, then we need to give them pre-treatment with oral contraceptive pills for 2 months and see that the LH levels come down, and then give them clomiphene citrate or letrozole. The other method is if the patient is obese, if she is having hyperinsulinemia, we have to treat this hyperinsulinemia, bring down the insulin levels, and this can be done by giving either metformin alone or myo-inositol. I nowadays give a combination of metformin and myo-inositol. This will take at least 2 to 3 months for the whole system to be corrected, and we cannot expect any dramatic results within 1 or 2 days. Now once the ovaries are sensitized, then you give them letrozole. Initially you can give 5 days starting from 2.5 milligrams from the second day onwards for 5 days. Supposing the patient doesn't have ovulation with this, you can give an extended dose of 2.5 milligrams to 10 days. There is another very good protocol in letrozole that is known as the step-up protocol, wherein we start with 1 tablet, increase to 2 tablets, then 3 tablets and 4 tablets. So these are all the various protocols of letrozole that you can give. Once you get ovulation and she conceives, that's fine, but supposing the patient doesn't conceive, then you can opt for oral ovilegins along with gonadotropins. Now supposing for some reason you don't want to give letrozole and you want to give clomiphene citrate, same here, give clomiphene citrate starting 100 milligrams for 5 days, and even here you can give an extended dose, because in PCOS sometimes the patients get such a irregular menstruation that you can go for the extended courses as well. And after this, if the patient doesn't conceive, then the next line of treatment will be gonadotropins. And in gonadotropins, as far as PCOS is concerned, you should remember that the best protocol is chronic low dose protocol. In this chronic low dose protocol, we start with very low dose of gonadotropin. You can actually, initially we were thinking that we should give FSH or highly purified FSH, but nowadays there is a concept that even HMG gives good results. So in a country like ours, we could also give HMG. The only problem with HMG is that we cannot titrate the dose to very low levels. So we sometimes prefer the recombinant FSH, where we can start the very low dose. Now give that low dose. Supposing you started with 50 IU, continue for 1 week and then increase the dose. So that is why this is known as chronic. So every 7 days you increase. So for this type of a protocol, the patient and the doctor both have to have a lot of patience. But then when you do this, you'll find that there will be definitely a monofollicular growth of the follicle, and there's less chances of ovarian hyperstimulation and also multiple pregnancy. sometimes the patients are very poor, they don't want to have gonadotropins because gonadotropins means a lot of money and every time they have to spend this amount. So then you can opt for laparoscopic ovarian drilling. Laparoscopic ovarian drilling has a lot of controversies, but then if it is done by an expert properly, it is good, it gives good results. And though I would not get into the controversies of so many punctures and stroma and all that, but then what generally is accepted is 4 punctures in each ovary, and with this the highest number of pregnancies are obtained in about 6 to 1 year. Then coming next line of treatment is the IVF. In IVF we have to be very careful, we have to, because these patients are really the ones who will have ovarian hyperstimulation syndrome. So best would be to give them, not to give them a trigger by HCG, but to give a trigger by agonist, and then freeze all the embryos and then transfer in the next cycle. There's one more advancement as far as treatment of infertility in PCOS, that is the in vitro maturation. But this in vitro maturation worldwide is not very popular, as it is very tedious and we need to remove the eggs from follicles which are as small as 10 millimeters, and the technique is difficult and the results are not very promising. So still it's underway of research, and some people though are doing it, so we can keep that also in mind. But the best part in today's era is that we can freeze all the embryos, and these frozen embryos can be replaced in the next natural cycle or the hormonal treated cycles. And because of this, many patients are able to get pregnancies without having the problem of the life threatening problem of ovarian hyperstimulation syndrome. And I think this should suffice for the treatment of the reproductive age group patients. But then one word of caution: when these patients conceive, you have to have in mind that these are the patients who are going to have gestational diabetes, and please do a GTT in the first trimester, second trimester. Be very vigilant, and I always continue the treatment of metformin etc. even during the pregnancy, so that problems of these gestational diabetes and these things are less. And I have seen that when we continue metformin and myoinositol etc. during the pregnancy, then the use of insulin is at minimum. I have seen so many patients, because mine is a tertiary center and I have treated many patients, and they do develop gestational diabetes, these PCOS patients. But we can really, if we keep it in mind that we have to diagnose early and treat them properly, so that everything goes very smoothly for these patients. Now I would like to throw some light on the management of adolescents who have PCOS, and I would like to tell the clinicians that please do not think that it's a very difficult area of management. In fact, if we understand the pathology and the pathophysiology that's happening in PCOS, it would be really very easy to treat these patients. Once again, I would like to repeat that lifestyle management is the first choice of option. If the girl is obese, we have to see that her weight comes down, and as I had already told, a lot of counseling, diet, exercise etc. really will help her. We can also refer them to other dietitians and physiotherapists etc. What I do as far as exercise is concerned is that I tell my patients that they should first think about the exercise and choose the one which they really love to do. If a girl doesn't like to do fast walking and we tell her you wear the shoes and do fast walking for 1 hour, she'll be fed up. Instead, if we give her a choice, do you want to do skipping, you want to do jogging, do you want to do dancing, do you want to do cycling, let her have the choice. Let her come out with one particular thing, and then you advise her, because that particular exercise or exercise in general, she doesn't have to do just for 1 or 2 months. She has to continue till she dies. That we have to make it very clear. And once she starts doing a particular form of exercise, she loses her weight, then she'll be really wanting to do or continuing to do exercise. So many times I even tell my patients that you can even dance, and for dancing you don't have to go to some gym or have expensive fees, etc. You can do it in a room, in your home, close the door, and just if there's a mirror in front of you, that would be good. Just put on some music and start dancing. So basically we should know how an exercise helps them, what are the types of exercises, etc. We have to advise them that initially they have to do a little bit of warming up, and then there are different varieties of exercise like aerobic exercise, stretching exercises, and also muscle building or strengthening exercise. So all these have to be done in proportion, and that has to be clearly explained to them. As far as dieting is concerned, it's really difficult, because if you be very strict with them, then they're going to have a binge eating. And so what you should do is cut them on all the fast food, etc. And you can allow them once in a month, tell them to go and have some pizza or cake or something, so they don't crave for that particular thing. With this we come to the problems of their acne, and for acne it would be also preferable if you could take the help of a skin specialist. And if you want to help them with the acne problem, there are many creams that are available, which you could prescribe, which contains retinoin, and you could also prescribe them course of antibiotic that would really help them, like doxycycline. And once again I would say that if the problem of acne is severe, it's always better to consult a skin specialist as well. And as far as hair fall is concerned, we have to check their thyroid, and if there is a problem of hypothyroidism, please put them on required amount of either L-Troxin or Thyronol. The dose is would be starting with 25 milligram, maybe up to 150 to 200 milligram, depending upon the case. Now coming to the hirsutism part. Basically in hirsutism, it really makes a girl feel very low because of the hair growth. So you need to give special care and attention for these patients. And as far as hirsutism is concerned, you could all advise them for the cosmetological purpose. They could either do a laser treatment, or they could also do waxing, etc. These days we also have creams of eptocorlin, and that is easily available. They have to apply twice in a day, morning, evening, and after application, after about 10 minutes, they can even apply sunscreen, etc. They can go out in the daytime, there is no problem. And these creams for hirsutism will take at least around 3 months to be effective. Now in some cases of hirsutism, there could be a raise in the testosterone levels, and in case there is a raise in the testosterone levels, then you should be giving them metformin as well. You could also combine metformin with inositol or minoxidil. Actually, I do like myoinositol because I feel that inositol is a nutrient and it is available in our body. It is there in our body. But these girls who have PCOS, they are excreting a large amount of inositol. When compared to the normal girls, they are excreting about 5 times larger inositol. So I think it comes to my simple mind that we should be supplementing them with myoinositol. In the pharmac name or the brand names have this myoinositol instead of inositol. Now coming to hirsutism again, here the oral contraceptive pills would really help these girls, and the type of oral contraceptive pills would be the ones containing cryptorelin, and in hirsutism the desperidone doesn't help. And as far as obesity is concerned, as I told you, the lifestyle will only help them. And for acne also and irregular menstruation, oral contraceptive pills is the first line of treatment. And oral contraceptive pills, you can give them any oral contraceptive pills, but you have to remember that they have to be low dose pills, and most probably the ones that are available in the market are like Yasmin or Fainal01, Novelin, everything can be. Fainal01 has a little low hormones, so that could be given as well. As I told you, you have to consider the pills which have low hormones in them, which will be helpful. How long to give oral contraceptive pills? You can give them for about 1 year, but then you have to keep in mind that these girls will have a lot of fluid retention and as well as weight increase in the weight, and you have to counsel them properly for these things. So और कुछ है? एक मिनट इसके बाद में. Dear friends, September is the month of PCOS awareness, and let's all take a pledge that we fight, all of us together will fight to take away this syndrome as much as possible, help our patients and try to reduce the incidence, at least the impacts of PCOS as much as possible. And I am very happy to share with you all that this is one of my latest books on PCOS, Decoding PCOS. And if any of you clinicians would like to read this book, you could write to me, or you could also get it from JP Publications. Thank you very much.